I am going to discuss the Roux-en-Y Gastric Bypass, and tomorrow you will perform this surgery also. So, this is very important surgery. You know, MGB is still some of the American they do not accept. They say that it is not a metabolic surgery, and they say that there is a high chance of the cancer. So, however, a lot of controversy still exists, as you have seen the lecture of the Rutledge, that it is not true. But RYGB is still the most frequently performed bariatric surgery in the United States of America, and it is the only surgery which is considered the realistic bariatric surgery, and this has a combination that is restrictive as well as malabsorptive. So, we will see how to perform RYGB. What is basically obesity? What happens that once we eat, that food enters into the stomach, and the duty of a stomach is to break it into the small particles. After that, through the antrum, the peristalsis enters into duodenum, and then pancreatic and bile juice get and they start getting digestion, and after that absorption, and through the lamina propria of the small intestine it is absorbed. Do you know, one literature was published that this microvilli of the intestine, surface area of that is that much that you can wrap one entire earth. If you calculate the surface area of the human microvilli, that is due to the purpose is to increase the absorption. And once we have the overnutrition, we become morbid obese. Now, RYGB the most frequently performed weight loss surgery in the United States of America. What is the full form of RYGB? That is Roux-en-Y Gastric Bypass. What is Roux? Roux was a surgeon, bariatric surgeon from Switzerland, who has given the concept of Roux limb, and Y-shaped gastric bypass has to be performed. That is why name is RYGB. So, what you have to do here? You have to make a gastric pouch, not a gastric tube like MGB. Here gastric pouch, and it should be teeny pouch which should have maximum volume of 20-25 ml, and then entire stomach will get disconnected from the remaining gastric pouch, all the other stomach. After that, from ligamentum trees, you will calculate the jejunum 30 to 50 centimeter, 30 to 50 centimeter from ligamentum trees you will calculate, and then cut that jejunum, and then the distal segment of the jejunum, this is called Roux limb, and this Roux limb we will do the Gastrojejunostomy, ideally end to side anastomosis by circular stapler. And after that, this is suppose 30 centimeter, this limb, then this will be 150 centimeter, and then you will do the remaining anastomosis. So, this is Y-shaped anastomosis. So, what is there that suppose this is ligamentum trees, then this should be 30 centimeter, and then this should be 90 centimeter, roughly 3 times more, and 30 centimeter you will fire the stapler to make a Roux limb, and if this is 50 centimeter, this limb, this is called which limb? BP limb, then this will be 150 centimeter. So, roughly 3 times more than the BP limb will be Roux limb. This is called Roux limb, and this is called BP limb. So, this is how gastric bypass is performed. This is also not a very difficult surgery. So, what happened that this part of the intestine, this 90 or 150 centimeter, it does not have enzyme, and this 30 centimeter or 150 centimeter from ligamentum trees, it does not have food, it has only enzyme. Am I right? BP limb, that is why it is called biliopancreatic limb, and this has only food. So, no any digestion. So, only that part will be working, and this 90 and 30, that is 120 centimeter, will be bypass. That is why it is called Roux-en-Y gastric bypass. If this you are calculating 50, then this roughly you will calculate 150. So, how much will be bypass? 2 meter. 2 meter is bypass. Now, how you will decide which patient you want 150, which patient you want 120, which patient you want 2 meter? That depends upon many factors. One of the important factor is age, and because if the patient is young, he can tolerate or she can tolerate even the more bypass, but patient is suppose 45, 50 reaching, then you should be little conservative, otherwise a lot of malnutrition will happen. Another BMI is also, if BMI is lower side, then you do not need to more bypass. BMI is higher side, you need more bypass. And dietary habit of the patient is vegetarian or patient is non-vegetarian. In non-vegetarian, we can take more bypass because they have high calorie diet, high protein diet. They do not have vitamin B12 deficiency because non-veg has already vitamin B12 and most of the thing calcium and all. And if it is vegetarian, then you should not do more bypass, and patient choice also you can do. So, this is the concept of doing the RYGB. So, let us see how to perform this surgery. Patient port position is same. This is the supraumbilical port that you will put 5 centimeter above the umbilicus. This is port number 1. After that, one right hypochondrium, one left hypochondrium in mid-clavicular line. So, these will be your working port. Here you will put the Nathanson liver retractor, and from here a stapler also has to be introduced. And this port anterior axillary line for assistant to hold the short gastric. So, these are the basic ports, however, little alteration on the port is always there. First step is that we have to make a gastric pouch that should be only 25 ml capacity. Here also you have to have a horizontal row of division and vertical row of division. But in mini gastric bypass, 12 to 20 centimeter gastric tube you are making. Here it will be gastric pouch, tube and pouch is different. So, if you will see on the stomach, there are 2 gastric pedicle which is existing. This is called first, you will put a bougie gastric calibration tube, 36 French bougie will be introduced, and inflate the balloon of the bougie, and then you will pull it up, and this is called first gastric pedicle. So, gastric bougie le aana, and this is second gastric pedicle. So, this bougie, once it is pulled, then just above the second gastric pedicle you will do the retrogastric tunnel. You will form the retrogastric tunnel and you will reach to the omental bursa, and during that process you have this bougie. This is the gastric calibration tube, 36 French, and 25 ml saline you will put it there into this. so that you will know that how much is the capacity of the stomach, and this is important. So, this is making a retrogastric tunnel. Lesser sac, just like MGB, but in MGB we go below the second gastric pedicle. Here you will be above the second gastric pedicle and below the first gastric pedicle, because here you will not make a gastric tube. What you have to make? Gastric pouch. And here we can see that this is reaching to the omental bursa, and here it is reached. Can you see this fat? Here it is reached, and this is the retrogastric cushion, and this retrogastric cushion is visible, and that is all. It is so simple. If you reach there, almost your surgery is complete. That much is only required in dissection part in this surgery, and it is over. After that, you will use the stapler and you will fire horizontal row of division. You see that this is the fat here. This, can you see that? This is the retrogastric cushion. It is visible here. That much only tunnel you have to make. And after that, you will take the stapler and dissect 3 to 4 centimeter. That means 30 mm or up to maximum 45 mm. So, only 2 or 3 times you will fire the stapler. That is, this is the stapler you will fire. This is called horizontal row of division. And once you fire, after that second line of division is vertical row of division, and then this will be gastric pouch. Done. What is the capacity? Only 25 ml. More than that, patient cannot eat at one time. And this you will fire. Here it is not necessary to make a dog ear because it is a low pressure zone. Blue cartridge you will use, or you will use purple or blue, and after firing it 1 and 2 times, after that you will pull it back, or you can use a smaller stapler 30 or 45 mm cartridge. It is done. So, this is horizontal row of division is done. After that, you will lift the stomach and check that there should not be any retrogastric adhesion. If the adhesion is there, you have to separate, because you have to put a cartridge now for vertical row of division. So, you will introduce this is vertical row of division, and you will fire. Here again you will fire blue cartridge. This is one, and another 2 cartridge is enough. This is 45 mm cartridge, that is why 2 is required. Otherwise in 60 mm many a time in 1 also is over, and it is done. We can see this is over, finished. So, you have a gastric pouch, teeny gastric pouch. After that, you will prepare for gastro. From here, this is what? Ligamentum teres. From here, jejunum start. So, this is jejunum. From here, this is BP limb, right? That is biliopancreatic limb, and here 30 to 50 centimeter you can calculate, either 30 or 50 or 40, it is up to you, depending upon your decision of the BMI. And with the endo-GI linear stapler you will cut. So, already you know that this is your endo-GI linear stapler, and already you have practiced how to fire, isn't it? You will load the blue cartridge or purple cartridge and you will fire. So, this is fire. After that, this mesentery also, either you can fire a stapler if you are rich, otherwise what we do, we apply ligation or harmonic for mesentery. Why? Because it has to be pulled up to do gastrojejunostomy, right? So mesentery also need to be little bit dissected. So this will be, after that, this limb is called Roux limb. This is Roux limb, and this Roux limb will go and anticolic, no retrocolic, and this teeny pouch which you have made, with this you will have end to side anastomosis. If you are using circular stapler, some people here also they use longitudinal stapler, then longitudinal stapler can only do which anastomosis? Side to side. It cannot do end to side. End to side only is possible by the circular stapler. And this is, after that, this BP limb will be do end to end anastomosis by enteroenteral, that is ilio-ileal anastomosis. So first you have to make a anvil. Actually anvil word is wrong here. This is called orville. Anvil word for circular stapler should be used if it is going through the anus. If you are going from the oral cavity, then correct name is orville, but common name is anvil, so we say anvil. So what we will do, you will take a orville and you will attach it with the NG tube in this orville, and then tie a knot with this hole there. You can see there are 3 holes in this orville, so that it should not become horizontal, it should remain longitudinal. So this suture will be gone through this hole and it should be tightened, and it is ready now. After that, this you will give to your anesthetist, and anesthetist will put it in the mouth. And nowadays infrared NG tubes are also available, just like we use infrared gastric calibration tube or infrared ureteric catheter, same way infrared NG tubes are also available. So you will put it, and then this is what? This is gastric pouch. So once anesthetist will put it inside, then it will enter into the gastric pouch, then you will perforate the gastric pouch and laparoscopically you will pull it, and once you pull it, then through the mouth orville will enter like that. It is done. After that you will cut it, this suture with the harmonic you can cut it. Here I am using scissor, but do not use this scissor, will anyway cannot be used, and it is cut and then it is removed. It will cut with the harmonic and it is removed. So this orville is ready. After that what we will do, that this is Roux limb. Once you staple the Roux limb, after that you will cut it, and from here you will put the gun. Gun will go from jejunum, and this is the gun which you will introduce, jejunum. How? I will show you the video. And then this is a perforator which will perforate like this, and then, and remember, it should not be perforate on the stapler, it should be side, it should be perforated from the side, and then these two will be connected. It is connected, and once it is connected, after that you will rotate it, and then you can see this is end and this is side. Now once it is fired, this perforation site also will be closed. how we will see in the video. So, here we can see this is preparation of the Orville, and how you will prepare? You will take a suture, pass this suture through the hole with the needle, suture with the needle, and then push this shaft of the Orville, you will insert in a NG tube. So, this is NG tube, not tip of the NG tube, tail of the NG tube you will cut. Why you will cut? There is a here there is a connector for the collecting bag, am I right? So, you have to cut it from here, and once it is cut then remove this connector part, and then this Orville you will be stem of the Orville will be fixed, and here it is fixing, and it is ready. After that it should not be horizontal. So, the suture which you have introduced through that, you will take a bite on the NG tube and tie a knot. There are two purposes. One purpose is that this Orville remain longitudinal, because if it is horizontal like that, it will stuck in the esophagus, it can damage the esophagus. So, you will take a bite and tie a knot, so it should be not horizontal, it should remain longitudinal. Nurse is holding, and you another that it won't come out easily during pulling it. So, it is done, it is ready, and now you can see it is longitudinal, Orville is longitudinal, it is ready. After that you will give to your anesthetist, and anesthetist it will put through the mouth, not through the nose. Yes, it should go through the mouth, and if you have an infrared it will blink, and then you will perforate the, just like in MGB how you are perforating, and then take this NG tube out, and NG tube will come out, and once the entire NG tube will be out, Orville will be like this, am I right? Like that, and this is ready to connect. So, we will do that. We can see here this is just a animation, and this is the suture, you will cut, and then this will disengage, and this Orville is ready for attaching. So, see this is blinking, because this is infrared NG tube, and then you will bring it, we can see it is blinking, and once it reaches there, then you will split with the harmonic, and pull the stem NG tube out, and NG tube is, this NG tube is coming in the abdomen, and entire NG tube should be pulled out, and this is the stem of the Orville. This suture you can cut with the harmonic, and this plastic also you can split with the harmonic, because harmonic is not a current. So, do not worry, there will be no direct coupling, because it is not a current, and harmonic even can cut plastic. Monopolar cannot cut the plastic, but harmonic can cut anything, and you will cut, and it is splitted, it is splitted, and now it is ready for anastomosis. You will leave it there. Your gastric pouch is ready for anastomosis with Orville. With Orville in the position, it is ready. Now you will go lift all the omentum and transverse colon upward, and from ligamentum tree you will start calculating 30 to 50 centimeter. Two way you can calculate. One way is by walking over 5 centimeter each time, and you will 6 time you will reach 30 centimeter. Another way, because 30 centimeter is not a very big limb, 30 or maximum 50, you can take a tape, and through the tape you can measure. It is up to you. So here is a tape, this is tape, and you will put a tape over the one end over ligamentum teres, and with the tape you can measure that where is your 50 centimeter or 30 centimeter, it is up to you. However, exact millimeter by millimeter measurement is not required. Few centimeter plus minus doesn't do any problem. So this is which limb? BP limb. And once you will cut, then this limb will become which limb? Roux limb. Roux limb. So it has to be divided from here by endo-GI linear stapler. For this you can use white cartridge also, blue cartridge also. And after that you will perforate on the roux limb and put a gun of the circular stapler, and then perforate on the side and then you will do end to side anastomosis. So this is a white cartridge which is used to divide the roux limb, division of the roux limb, 50 centimeter from the ligamentum teres. So it's done, it is fired. After that, here on the mesentery also white cartridge is fired, but it is up to you. Mesentery you can use ligation harmonic, and it is fired. So it's done. Now after that, this is which limb? BP, and this is roux limb. So now both the limbs are closed. This is also closed. So roux limb you have to perforate just adjacent to this staple line. Why? To introduce this gun. Gun has to be. Pardon? This one, this is 30, the total 22 mm is the diameter of the orville. So it will directly go percutaneously, but you will cut 30 mm completely. So here, without cannula, yes, it cannot go through the cannula because it is circular. Am I right? So directly you have to go by the wound protector with the anterior axillary line, this port, mid clavicular line through this port, your left hand port. Directly it has to go. We will see that. So this is how you will perforate it. And be careful that this should be fully perforated, completely perforated. Bile should be visible. You can see lumen is open. This is perforated, lumen is open. And what is this? A staple line. This is your stapler line, horizontal staple. Just lateral to the staple you will perforate. After that, this is the mid clavicular line, left side port. You will use a wound protector. Because why wound protector? I will tell you later. Because that will contaminate the wound. That's why this is a polypropylene wound protector. And this stapler is directly going through the enlarged incision, and it goes inside. And this circular stapler is entering into the roux limb. Where it is entering? The place where you have perforated. Through the perforation, because it is too thick, so it will enter into the roux limb and it is introduced. Is it clear to you? And it is entering. and after that this perforator will perforate the anti-mesenteric border of the Roux limb, and this is perforated. You will remove the perforator. This is a plastic perforator. Nowadays metal perforators are also there, and after that this orville will be attached with the gun, and this is end and this is side. Is it clear? So now this orville is attaching with the gun, and remember, it should, at that time it should not be vertical, it should must be horizontal, isn't it? Then only it will fire, and then outside you will rotate it clockwise direction, and orville will come near the gun. You have to rotate this clockwise. If you will do anti-clockwise, see, it is going away. Here it is going away, and when I rotate clockwise, it is coming nearer like this, and it is tight. And after that, one firing will do the job, and this is coming nearer to each other, and anastomosis happen. So you can see here, this is, what is this? What is this? Gastric pouch. What is this? Roux limb. What is this? Perforation. Am I right? And see, outside when you will rotate it, then anvil and gun, orville and gun come nearer to each other. This is pouch, this is Roux limb, and then fire, this is your gun. And once you fire, side to side anastomosis has occurred, and then orville will come out with the gun together. It is pulled out and it is coming out. It is out. And now, because it has gone through the bowel loop, so it is infected. So this wound protector will not allow to contaminate. Now you again need a port. Right now it is a 20 mm incision. Can you see that? Now again you need a port. So in this wound protector, you can put the port and then tie a knot so gas should not leak. And then this perforation, you will again fire a stapler. Is it clear to you? Once you fire the stapler, what will happen? This close, and that much tissue will be sacrificed, because it has to be removed from the body, and it will come out again through the wound protector, so it will not contaminate the wound. So this is which anastomosis? End to side, and this is fire and it is closed. After that, this Roux limb you will catch with a grasper, and then you will 50 ml methylene blue you will inject, and this methylene blue should not leak. What are the places which can leak? One is anastomosis, should not leak. Another closure of this should not leak, and another this vertical limb which you have made linear stapler, that also should not leak. So these three places carefully you will observe, and then gastrojejunostomy will be observed, so that there is no leak. So we can see here, now this is the longitudinal stapler which is closing this perforation which you have made for a stapler. A stapler has gone through this perforation, and you will fire, and this is called closure of Roux limb, and this tissue will be destroyed. That much tissue we will sacrifice, it will be removed from the body, and it is fire, done. And now it is closure of Roux limb is over. After that, this bowel loop will be removed, and now this is a long atraumatic grasper long jaw holding the roux limb, and then you will distend it. See, it is distended. So this is houch, this is pouch, this is what? Roux limb. And here you will check that there is no any leak from this side to end anastomosis, no leak from vertical, no leak from here. So you can see it is bulging out, distending, but it is doesn't turn blue. You can see it is bulging. 50 cc methylene blue check is done, and you are sure that there is no leak. So your gastrojejunostomy is over. After that, enterostomy will be performed, and for that, this is which limb? Roux limb, and this is which limb? BP limb. And here 100 to 150 centimeter roughly. If this is 30, then this is 90. If this is 50, then this is 150. Am I right? So now this is also closed already. So you will perforate here and here, and you will do side to side anastomosis. What is the biggest advantage? That there is no chances of biliary reflux. Not possible, because it cannot go antiperistaltic. Am I right? That's why even in the MGB you should make a long gastric tube. If you will make a very short gastric tube, there will be biliary reflux, because this is a combination procedure. But according to Rutledge, MGB is not a combination procedure, it is a malabsorptive procedure. This is very important. So now you will have here side to side anastomosis. So let us do now and see that you will perforate the anti-mesenteric border of the BP limb and roux limb 8 mm. 8 mm you have to perforate, as I told you earlier, and one jaw will go inside, another jaw will go here, and this is 8 mm this side, 8 mm this side, but make it sure that lumen should open. Sometime accidentally you have only subserosal firing. So bile should come, you should see bile coming, and then you will do, and this is called H-shaped anastomosis, which we have already done and we have seen. And this is done by suturing, closure is done by suturing. Horizontal, here it is in animation it is showing vertical, but actually horizontal suturing will be done. So now we can see here that these are the two limb and it is perforating the limb. You can use harmonic, you can use scissors with the monopolar to perforate both the limb, BP limb and the roux limb, and then endo-GI linear stapler, white or blue, both the cartridge you can use, it is introduced, and then you will fire. Now H-shaped anastomosis has occurred, and it is done. Now this should be closed by the suturing. So suturing should be full thickness. It is not only seromuscular, out to in and in to out. Full thickness suturing you will do. Completely out to in, including mucosa, and then in to out. So this is how Roux-en-Y gastric bypass is performed. Now complication is a lot. 0.3% incidence in many study incidence of anastomotic leak. Again 0.33% venous thromboembolism, 3 to 5% incidence of wound infection, 3 to 15% incidence of marginal ulcer, 7% incidence of bowel obstruction, 4% incidence of post-operative transfusion, and 1 to 19% incidence of anastomotic stenosis, especially based upon the type, especially in end to side, chances of stricture is more, stenosis is more. In side to side, then it is less. End to side it is more, but end to side has a better advantage that your restrictive procedure also works, isn't it? In side to side, more dumping syndrome will be there. So, anastomotic leak in the immediate post-operative period, anastomotic leak is single most feared complication, either open or laparoscopic. High incidence of the index of the suspicion, inappropriate approach, tachycardia, tachypnea, fever, oliguria. These are the most common symptoms that arouse the suspicion of this problem, and most of the time it is diagnosed third day. The treatment of surgical, except rare circumstances where drain may seal itself, but it is immediate surgical intervention is necessary. Stomal stenosis in gastrojejunostomy has been remarkably reduced due to use of linear stapler technique. So, stenosis will not happen, and stenosis symptoms usually appear 6 to 12 weeks post-operatively, but less commonly can occur later also. Sometime after 6 months of surgery also stenosis is reported, especially if the patient is alcoholic and all. Diagnosis only by upper treatment, upper endoscopy, and early treatment is endoscopy dilatation, balloon dilatation by endoscopy. So, resolution normally occur with 1 or 2 balloon dilatation session. In one session, balloon dilatation go and dilate the anastomosis. Marginal ulcer is also, and your fistula also sometime form, that is gastric fistula. The pouch may patient present with the pain in epigastric region, and then diagnosis by endoscopy. Treatment is proton pump inhibitor, which are effective in 90% of cases. Only those gastric fistula to the distal stomach, severe stenosis of the lumen of the gastrojejunostomy or acute perforation require surgical therapy.
What fistula is this?
This is gastric fistula, means remaining pouch will get fistula with the remaining gastric. Yes, but doesn't need anything, you can just give the proton pump inhibitor, it works. Yes. So, in only severe stenosis cases it is closed, because fistula will start taking the food. Now, surgical factor of GG, incomplete separation of gastric pouch, means when you are firing it, you know, when you do the horizontal firing, then still little bit was there, it was not completely transected. You got my point? Then fistula can form. Tension or ischemia of the staple line leading to dehiscence and fistula formation. Post-operative complication of this fistula is ulceration of the gastrojejunal anastomosis, chronic inflammation or infection, marginal ulcer or break, and foreign body reactions such as from suture, staple, and these also sometimes promote the fistula development. Staple or any foreign body like suture, ethibond and all can create the fistula formation. Dumping syndrome is also a problem. 50% of the patient will experience symptom of flushing, crampy diarrhea, palpitation and diaphoresis after ingestion of meal rich in simple carbohydrate. So dumping, you have to educate the patient that they should take care and they should not take tons of sugar, coffee, cold drink, this should be avoided.
If we use what size circular stapler? 83?
Circular stapler is 2.2 millimeter, 2.2 centimeter in the diameter. What is your question?
We have 28. We have
That is for colon.
okay, so this is a different one.
Yes. So this may contribute to many people, they like dumping syndrome because they say that it is anyway useful, because dumping contribute to weight loss, because the people who are grazer or carbohydrate eater, due to fear of dumping, they will avoid carbohydrate, which has the main cause of weight gain, and they replace the simple sugar with the high fiber carbohydrate and protein rich food they will take. A small bowel obstruction happens, and this is a complication must be treated differently than in average general surgery patient, whose complication is usually from adhesion and often will resolve with the conservative non-operative therapy. The patient who have laparoscopic RYGB who present with obstructive symptoms generally require surgical therapy on emergent basis. You should not treat it like a general surgery subacute obstruction, because here you have a abnormal anatomy and sometime your roux limb will get trapped in the bowel loop and then there will be a big complication. So immediate surgical intervention should be done, because bowel obstruction after laparoscopic RYGB is an internal hernia and from inadequate or non-closure of the mesenteric defect, and that is also a big problem, whereas it is not a simple subacute obstruction. Simple subacute obstruction, just by conservative nil orally it can resolve, but this internal hernia sometimes create gangrene. Nutritional complication is a big problem in laparoscopic or any RYGB. This is what is less in the MGB. And MGB, the RYGB average mortality is 1%. Average mortality 1%. And in MGB 1 in 500. Morbidity in RYGB is a lot, morbidity in MGB is 1 in 80. So post-operative nutritional complications, 66% of the patient has iron deficiency, 5% incidence of iron deficiency anemia also, 50% of the patient has vitamin B12 deficiency, especially vegetarian, and at least 15% of the patient has vitamin D deficiency, which is usually present post-operatively. So after RYGB, a significant proportion of the stomach including the parietal cell is bypassed, and gastric acid is essential of converting ferric iron into the ferrous iron, and without sufficient acid iron deficiency happens because iron absorption decreases. It is bypassing the iron absorption site. Major bypass absorption of the iron is duodenum and proximal jejunum, and that area is already bypassed. And this is why maximum patient has iron deficiency, anemia, and iron absorption is hampered. Mortality is 0.09 to 0.1%. However, mortality rate more than 65 is as high as 4%. So this was regarding the gastric bypass, Roux-en-Y gastric bypass. Is there any question? What you should select? You know, in Indian condition, we don't do RYGB. Reason being, our patients are not strictly dietary advice, they don't follow. They are not medically very educated and they have a lot of malnutrition problem. You need 1000 milligram calcium every day and you need at least weekly vitamin B12 injection and daily vitamin B12 tablet. 1000 milligram elemental calcium every day per day. Here it is written 1200 to 1500, but average 1000 milligram because of our patient height, and then vitamin D also every day. So these all is required. 3000 international unit once daily. So these are important. You should do bone density also. This is the average you have to give, and weekly also you have to give injection of the B12 intramuscular, either monthly or weekly, and oral every day. So these are the factors which creates a big problem. And our patient, you know, most of the Indians are vegetarian, especially in the Hindu family. So they are already deficiency in the vitamin D and B12 anyway. So these are the problem. That's why we don't do RYGB for Indian. Yes, when they from patient who is from Iraq or other country or Americans who come British, then RYGB is good. Indians RYGB they don't tolerate. They tolerate MGB and they tolerate sleep. So sleep is the maximum surgeons are doing in India because of no problem of any malnutrition. Because it is a restrictive procedure, it doesn't have any malabsorptive component. However, deficiency happen there also, iron especially, because it is not converting into ferrous. It is in ferric format, but at least you have the sleep. But here in pouch, this is a small pouch, create more iron deficiency. So, any other question?